So we are live.
Can you see me now? One second.
Praful sir, we are live.
Praful, can you see me?
So we can see your slides, but then we are not able to see you.
Unmute करना पड़ेगा. Should I just unmute this thing?
Yes.
Praful sir, we are live.
Yes. Good evening, everyone. So we are ready with yet another episode of Retina module, and this is a very important topic: choroidal neovascularization membranes. And we have one of the eminent speaker and expert in this field, Dr. Sanjay Mishra sir, and Dr. Ankur will introduce our speaker, and then we'll start the lecture. Dr. Ankur, please introduce our speakers, and then we'll move on with the lecture.
Thank you, sir. It's a moment of honor and a privilege to introduce Brigadier Dr. Sanjay Mishra. Sir is currently head of the Department of Ophthalmology of Army Hospital, Research and Referral in New Delhi. He is an ophthalmic surgeon to an Honorable President of India. He is the highest decorated doctor in the history of Indian Armed Forces. He has been awarded by 5 presidential medals, including Ati-Vishisht Seva Medal, 2 Sena medals, and 2 Vishisht Seva medals. He is a renowned vitreoretinal surgeon trained at RP Center, AIIMS, New Delhi. Sir is going to talk about a very important topic, which is choroidal neovascular membranes. Over to you, sir, and please start with your slides, sir.
Thank you, Ankur, for this elaborate introduction. So this is a very important topic from the point of view of examination. So we are focusing more on examination, and also once you graduate, and then this is a very common topic and common condition what you can face in your normal condition. So I shall be speaking on the choroidal neovascular membrane. So what is the definition of a choroidal neovascular membrane? Is that it's a pathological development of new blood vessels. So there are 3 potential spaces, that is a subretinal space, there's a sub-RP space, or it could also develop intraretinally, along with exudation and fibrovascular changes. That fibrovascular change is very important because once you have those fibrovascular changes, that is why we call it as a membrane. So various nomenclatures have been used for describing these conditions. Firstly, it was called CNV, then it became CNVM, and now in recent articles and recent nomenclature is MNV, that is macular neovascularization. So how does, we'll speak of CNVM at macula. That's very important because CNVM can happen at macula and also away from macula. So the one which is picked up early, which is at macula, it will normally present with blurring of vision. You'll have patients complaining of, this elderly group coming back to you and saying that, no, I need a change of glass. I went for a change of glass, and despite the change of glass, I am still not able to see well. I have already undergone cataract surgery and still there is a blurring of vision. So this is very important presentation, that initial blurring of vision. Then when it progresses, it can also cause diminution of vision. It can lead to loss of contrast and color. And of course, it can also present with waviness of lines, that metamorphopsia. So peripheral CNVM can also be present. Just a second. This I need to. This portion needs to come down. If you can, on this side. So peripheral CNVM can present as peripheral scotomas. Suddenly, it can also lead to a massive subretinal hemorrhage, which can produce a good amount of field loss. But all these cases, as I said, that macular CNVs can be detected early, whereas a peripheral CNVM usually goes unnoticed and they are usually asymptomatic. So what are the common unifying pathogenesis? There is a primary role of VEGF. We all know that VEGF, how important it plays role in angiogenesis. And of late, there is also role of associated inflammation. And that is the role why, if we see that if the inflammation is there, the role of new anti-VEGFs like faricimab, which acts on the Ang2 receptors. So, thank you. So, what are the etiology of that? Etiology of CNVM? The foremost is AMD, pachychoroid, which I will be dealing later, myopia, post-trauma, inflammatory, idiopathic, or it could be associated with inherited retinal disorders. What are basic essential investigations? It's we all know, and now everybody is so heavily reliant on OCT. OCT of macula is one of the most important investigation and initial investigation. What are the things we get information on OCT? That it tells you the type. That means type. It could be a subretinal. It could be a sub-RP. Well, basically, I'll be dealing on the types of CNV based on OCT. Then decision to treat, whether there is a intraretinal fluid, there's a subretinal fluid, or there are the hyperreflective dots which are present. So that will all be an indicator to start your treatment. Then your monitoring of response, all these studies and everything which is done, you monitor your patient on OCT. That's very important to see how well the patient has responded or how well he's deteriorating on the treatment. And of course, you also look for the pachychoroid. Fundus autofluorescence is basically, it's more used in dry AMD. It tells you about the health of the retinal pigment epithelium and photoreceptors, and also associated CSCR and uveitis, where you see those hyperreflective dots. Again, a new modality which is now commonly used is OCTA. It's a non-invasive dilus angiography. Important aspect in OCTA is to see for a scar tissue. It's very important to see where the end point of treatment, that means beyond this, the treatment is not required, and you see that as a dead tree appearance, which I will show you later as my presentation goes on. The fluorescein angiography has been earlier the gold standard of investigation. It will tell you about the type of CNV, that is whether it is a classic CNV or it is an occult form. The other etiologies are, if present, can also be deciphered well. And of course, the ICGA, that is cyan gray angiography, will tell you about the hotspots and the polyps. So what are the common unifying treatment is that laser in CNVM is the gold standard for treatment if you accept the collateral damage. So if the CNV is away from the fovea, laser becomes the first and the foremost form of treatment, because you can reduce the load of treatment in these cases. Second, what we all know and we all see in daily practice is use of various anti-VEGF drugs. And if there is an associated inciting factors like inflammation, steroids, whether it's intraocular steroids in form of implants or oral steroids, are important. And of course, we see that role of antioxidants in various studies, which has proved beyond doubt that how antioxidants play a very important role in halting the progression of this disease. Of course, we all know that supportive care in form of low visual aids and environmental modification, like increasing the light, asking the patient to be careful while going down the staircase, and other factors which needs modification, bringing a positive environment of this patient is absolutely important. So we come to the age-related macular degeneration. So it can be classified as non-exudative, which we all know as dry AMD, and exudative, which is otherwise known as wet or a neovascular AMD. We classify no AMD if we see few, that is between 5 and 15 small, that is less than 63 microns drusen, or no drusen without any pigmentary changes. And early AMD, if you have several small, few intermediate size, that is intermediate size is important because see, these are all, you will not be able to appreciate it clinically, but theoretically you should all know, because usually it is asked in examination about the size of this drusen. That is, its intermediate drusen is between 63 and 124 micron, and or without pigmentary changes in one or both eyes. The intermediate AMD, it is extensive drusen, that is 20 soft or 65 hard without any soft drusens. Intermediate drusen, one of them should be more than 125 micron drusen, and or geographic atrophy not involving the macula. Very important that macula is spared of the atrophy and other features are present, then we call as an intermediate AMD. And the advanced AMD, we see that advanced dry form, that is macula involving geographical atrophy, or exudative form with CNVM present in one eye. So what are the risk factors? Risk factors can be classified as modifiable and non-modifiable risk factors. So smoking is a very, very important risk factor. It increases the risk of AMD in almost twice. And even after you quit the smoking, the effect lasts. So it is very important. And in our country, it's also important. You will ask history, कि बाबा आप cigarette पीते हो, बीड़ी पीते हो, बोलेगा नहीं. But then you must also ask the history of tobacco chewing. Very important. Is almost same as eating tobacco, chewing tobacco is as same as smoking. So it's very important to ask the history for smoking. Obesity, we all know, the higher BMI increases the chances of AMD. We all know that antioxidants, how carotenoids and lutein play a role in decreasing the incidence of AMD. A dietary fat intake, other conditions like hypertension, cardiovascular risk factors, they all aggravate your chances of getting AMD. Now, the cataract surgery, which has been mentioned, that was there when the older generation of lenses did not have this filters, the Brew filters. So all those filters now, the new generation lenses have all those filters, and practically after the cataract surgery, it is no more risk factor. The other non-modifiable factors is age. We all know that it increases with each decade. That is, after 50 years, it increases every decade, increases the chance of AMD by 50%. It doubles. Gender, that we all know that ladies, the females are more at risk, especially after 75 years of age, with a ratio of 2:1 after 75 years of age. And white population is more at risk than black population. It has not been studied in the Indian population as such, where various studies have been done with North India and South India, but it is not compared. The genetic factors, definitely at the familial cases, it plays important role in 10 to 20% of cases. And the dark color of iris is protective. So the pathogenesis of CNVM, macular CNVM, is important. We all know how does the RP function. The RP is the most important function of RP is to engulf the part of dead or the dying photoreceptor, the outer part of the photoreceptors. It is taken up by the RP. The materials from the photoreceptors is engulfed and is digested by the lysosomal enzymes, which is present in the RP cells. And the undigested material gets accumulated as lipofuscin. This excess lipofuscin decreases the functional capacity of the RP cells and thus impedes the function of RP, and thus it is the genesis of macular degeneration. It's very important to know that this is the aspect how the genesis of AMD happens. So we all know that photoreceptors and RP, they release, the dying photoreceptors and RP release VEGF. And this VEGF is the precursor for the new vessels. These new vessels are very fine vessels and they grow behind macula, and there is a Bruch's membrane. As the vessel starts growing, it grows as a lumen. You know, it comes as a small bunch. It breaks through the Bruch's membrane and it canalizes into a lumen, starts going as a luminary vessels. And these vessels are very fragile and they leak blood and fluid, thus resulting into hemorrhages. And you can see what SRF is because of the leakage of the fluid from these new vessels. And ultimately, as we all know, as it progresses, because of the other factors and the inflammatory cells, it causes fibroblasts to develop and it heals and it treats with scarring at the macula. And once the macula is scarred, it can lead to a severe damage of the vision. This is how you can see the choroidal neovascular membrane, which is present under the Bruch's membrane. It breaks the Bruch's membrane and goes into the subretinal space, and it establishes the choroidal retinal anastomosis. This is, if you see the difference between the two pictures, on the left side is the retina of a 3-year-old child, and on the right side is an 80-year-old person, where you can see on the left side there's no drusen, whereas it is present in the right side. And if you see this, the phagolysosome containing A to E, that is very important. That is the precursor for it gets stored into lipofuscin and is the precursor for the damage, the further damage and causing of the AMD changes. So the clinical features is very important. As I say that in early stage, it is usually asymptomatic. But when it progresses, the patient complains of difficulty in reading and frequent change of glasses. Even with the glasses, he's not able to read, especially the newspaper. He says, I'm not able to read the newspaper. The moment the light is dim, it has become very difficult for me to read the newspapers. And he can manage with mobile because the mobile is backlit initially. So there could be a delay in presentation in case the patient is not doing a heavy reading. Then he can come with a minimally blurred central vision, a loss of contrast and color, and metamorphopsia. It's very important that he can see. He says that what line I'm reading, what I'm reading appears wavy, zigzag, or the words which are there, it gets jumbled up, or there are words in the center of the reading page is missing. So these are the initial symptoms. So how does a wet AMD present? Usually it presents as a painless progressive diminution of vision. It can suddenly, the patient can come with sudden blurring, sudden diminution of vision when there is a subretinal hemorrhage from CNVM, that is a breakthrough bleed. And it could also be insidious in nature when there is a shallow subretinal fluid or a PD present, especially if it is around or under the fovea. The signs, when you examine this patient clinically or a 90-day examination, you can see a plaque-like membrane or a gray-yellow discrete discoloration of membrane on the posterior pole. You can also appreciate a subretinal fluid. You can see macular edema. You can see subretinal or sub-RP hemorrhage, subretinal lipid exudates, PDs, drusens, or it can also cause breakthrough vitreous hemorrhage and also can present as disciform scar. See this. This is what it presents. You can see a hemorrhage which is present. You can see which is surrounded by the drusen and also the sharply demarcated serous macular detachment. This is how the patient, and this is if the bleed is subfoveal initially, then he's going to come with a gross diminution of vision. Please treat it again like a case of a retinal detachment. It's an emergency because subfoveal bleed can cause, it can coagulate and it can cause damage to the photoreceptors, and even if it displaces the vision recovery is not so good. So it has to be treated, which I will tell you how it has to be treated for those conditions with a subfoveal bleed. This is the initial presentation of a patient. If you dilate and see the fundus examination, you can see these features. The drusen's are important because I will tell you about the condition which is happening without drusen later on in my presentation. So again, if you can see this subretinal hemorrhage, this is if it is away from the fovea, it may go unnoticed, but if it involves the fovea, it will definitely give. You can see the drusen surrounding this. This is the end result. You can see those blood vessels also in the scar. These are mature blood vessels, and you can see a central disciform scar and results in a very poor vision. So what is a disciform scar? It is the end result of CNVM. Now it happens because there is a continued exudation, bleeding, proliferation of vessels. There's a hyperplasia of RP cells leading to invasion of fibroblast and inflammatory cells causing scar formation. That fibroblast is very important. And it's important to see that you can, even in the scar tissue, you can see those vessels. So you should not, think even if there is some amount of intraretinal fluid and there you can see those the mature vessels in the scar, please do not jump and over-treat these patients because they are not going to benefit much. It appears as a white and fibrous appearance. So how do you diagnose it? So when you do FFA in AMD, it is basically you differentiate between a wet and a dry AMD. The location of CNV is in respect to the foveal avascular zone, very important, whether it is next to the fovea, subfoveal, because the treatment pattern will change. The determination of pattern, again, whether it is a wet, it's a classic or an occult form, and the boundaries were exactly, because these were the pattern which is more important for the treatment when we are using a PDT or a laser, because the boundary is important. You calculate the size of this area and then you treat that complete area with laser. Also, you determine the treatment and monitoring of the treatment on FFA. In wet AMD, FFA, we know the patterns which I've told. The pattern is classical CNVM or an occult CNVM. So occult can be again two types, fibrovascular PD or a late leakage from undetermined source. These are very important theoretically. It may not be holding very importance practically, but very, very important to know theoretically. So this is again a classic CNV. If you see this pattern, now if you see this is important when you are asked in examination, how does a classic CNVM behave on an FFA? You have to say that it gives a lacy pattern of hyperfluorescence, which starts early in the early phase, and it increases in intensity and extends beyond the margin of hyperfluorescence as the FFA progresses from mid to late phases. Whereas the fibrovascular PD, the stippled hyperfluorescence in mid and late, that means it is a stippled, the words are stippled hyperfluorescence in mid and late phase. And this late leakage of undetermined source, it appears poorly demarcated speckled hyperfluorescence. So earlier it was stippled, now it is speckled hyperfluorescence, which occurs 5 to 10 minutes post-injection. This is how the disciform looks on an FFA. You can see demarcated, well-demarcated hyperfluorescence, and the boundaries are not breached, that it does not go beyond the boundary of the initial hyper. This happens because the scar tissue takes up the dye and it appears as a hyper. It will not increase, it will remain constant and it will not increase in the fluorescence. Depending upon the amount of hyperfluorescence, it could be a predominantly classic, where the lesion is more than 50%, or minimally classic if the lesion is less than 50%. If you see this, if you see on the right side, you see a large lesion on OCT, you say that, it's a big lesion. But if you see on the left side, then FFA, only a small portion is what is the CNVM. The rest of the portion is, you can see just the stippling And the area, so this area, this is important because when you are using lasers to determine the size of the spot. So depending upon the laser, as I told you, when it is when you are going to use laser, it is applicable then. When it is subfoveal, it is just under the fovea. Juxtafoveal between 1 to 199 microns from the foveal center, and extrafoveal when you have more than 200 microns from the center. Why this is important that subfoveal and juxtafoveal, we do not think of doing lasers because the lasers can damage the foveal center and you can have a permanent loss of vision. But when there is an extrafoveal CNVM, the treatment of choice becomes the laser. So laser is important when you have an extrafoveal lesion. So ICG is in wet AMD is very, very important in the sense it can, suppose you have a bleed in the retina, and the classical teaching is that no, you have to postpone your angiography till the bleed settles because you can't see anything to that. There comes the role of ICG because it can pick up choroidal circulations even in presence of retinal lesions, which would have otherwise prevented the visualization on FFA. So the uses of ICG, so FFA cannot differentiate between an occult CNVM and RAP lesions. So RAP, I will tell you, it's a type 3 CNVM, but RAP is a very aggressive form. So you are going to treat, if you just limit yourself to FFA, you are going to treat occult CNVM as RAP CNVM. And 1/4 of cases of occult CNVM are RAP. That is why it is important to do an ICG in cases. RAP is usually present in the center of PED, or it could be present at the margin in case there is a fibrovascular PED. Here, if you see this left side, if you see this is an FFA. You can just, because barely you can see the hyperfluorescence, you will say that yes, there is a CNV present. But if you see on the right side, there is a dipping vessels. That is the RAP lesion. You can see the vessels which is dipping from the retina to the choroid. That is the feature of a RAP lesion. So why we should know this? That because it is ICG angiography is better delineating CNV in almost 40% of cases, where the normal fluorescence will show a very poorly delineated CNV. So why this is important? Because ICG, the larger vessels are, they fill up earlier, unlike the other where the smaller vessels fill up earlier. Here the larger vessels fill up earlier, and as the angiography progresses, you can see the smaller vessels getting filled up. And this is the biggest barrier for ICG is RP. So if there is a loss of RP, you can have a better visualization in ICG. And if the RP is intact, then it can cause a barrier in the visualization of the ICG. The terms normally what you use as hyperfluorescence in FFA, here the terms are different. You have to use a hypersenescence and a hyposenescence in ICG. In ICG, the AMD appears as a hot spots or plaque. In PCV, it is very important because it becomes the prime diagnostic tool for a PCV, where you can see the BVN, that is branching vascular networks, and the polyps which are present at the end of the BVN. In case of a CSC, early hypersenescence is seen. You can see that choroid vessels, it shows hypersenescence in cases of a CSCR cases, and that's very important. Because you can get confused doing an FFA, because FFA will show you only a leakage, and here it will show you an early phase only, early hypersense in the choroidal area. This is what you see, a classical CNV, PCV. That is the role. Now, the role of a multimodal imaging has come. If you see on the left side, the feature, you can, based just on the fundus photograph and OCT, you will not be able to make it out that it's a case of a PCV. You will keep on treating this patient as a conventional CNVM, whereas it will behave in a different manner. If you see the fundus angiography on the left side, you will just see a membrane. You will say that, yes, it is a CNV. But if you see on the right side in ICG, you can see those polyps. These are the polyps. And if you do this OCT, you can see those the features of PCV, which I'll tell you, the OCT features of PCV, which I'll tell you later. So this is more clearly on the left side. You can see those membrane. You will see that it's a simple or CNV, but on right side, you can see those polyps. These are the polyps which are getting better visualized. You can see those polyps. And you should go through the phases and follow the polyps. And you can see the polyps, which is multiple polyps. So you will not be able to miss out on this on ICG. So not every CNV and PD is picked up. So in this case, if you see this, you may miss out CNV or picked. That is the role where the ICG plays a role, where you can detect those CNV. Now, OCT helps you in classifying a wet AMD. This is important from the point of view of examination, that you're asked what are the types of CNV, and on OCT, there's a type 1 CNV, which is a sub-RP CNV. Type 2 is a subretinal. Type 3 CNV, that which I was talking about, is a RAP lesion. RAP is retinal angiomatous proliferans. And sometimes even type 4 is described, which is a combination of type 1 and type 2. Apart from that, it will also tell you about the intraretinal fluid, the subretinal fluid, and the sub-RP fluid. The neovascular lesions growing in the subretinal space are associated with a large volume of subretinal fluid compared to the sub-RP lesions. So this is typically type 1 CNV, where you can see type 1 is a sub-RP. So you can see under the RP, you can see those CNVM. This is the type 2. It is subretinal. You can see that the RP layer is intact, and the CNVM, which is above the RP layer. This type 3 RAP region needs a special mention, because it is a very, of all the CNV, it's more aggressive form of CNV. It is easily missed out. It is very important that it's, and it is the reverse form, that is the retinal proliferation, that neovascular proliferation is not happening under the retina, but within the retina. And the retinal choroidal anastomosis is formed in this case. You see this. This is the vessel which is, if you see this, the vessel which is dipping from the retina into the choroid. On OCT, if you see this, you can see this, in the OCT, there is a cystic space. That's a very good indicator of a RAP lesion. You will see a cystic space in the OCT. And the lesion, since it is in the intraretinal, it will press on the RP, and you can see that it is pressing down. The vessels, if you see, there's a dipping of vessels, which is going from the retina to the choroid. Again, this is, if you see this, the central space, the cystic spaces. There's another lesion which is known as a tubular lesion. If you can see retinal tubular lesions, these are the tubules which are present throughout your scan, and it is central lumen. The size of this tubular lesion does not. It will not form any part of your modification of treatment, will remain there. It will not cause any problem, and these should not be confused for the RAP lesions. Again, if you see the disciform scar, you see the left side of the scar, you can see those mature vessels which are going through the scar. Initial picture, when you see the fundus, you will say that, no, there's an active CNVM, and you need to give this injection. But if you see this, if you do an OCT, you can see a scar tissue without any fluid. So these forms the end stage of the CNVM. PCV, that's very important when you do an OCT. These are the 4 pictures on OCT, which is commonly asked in your examination, is what are the features of OCT. And in a PCV, you can see in the first picture, it's a sharp peaked PD. The second is a thumb-like polyp. Again, is a thumb-like PD, which is known as a thumb-like polyp. There's a notched PD. You can see there's a notching of the PDs there. There's a notching usually present nasally. And then this is a double layer sign. You can see those the RP is present, and under that RP, there's a Brooks membrane, with there's a separation of the RP and the Brooks membrane because of the fine layer of fluid. So this is a double layer sign, which is commonly seen in PCV. OCT is also used for exclusion of certain diseases. This is a condition, if you do an FFA, this was a condition where you can see if you see a cyst on the macula, you can initially think that it could be a CNV, but if you do an OCT, you can see there's a subretinal fluid and a very small flat PED here. And of course, then you know that there are hyperreflective dots on this OCT, and this is a case of a CSCR and not a PCV, not a CNVM. Again, if you see the cystic spaces on macula on clinically, then again you do an OCT, you can see those perifoveal cyst distribution and a case of a CME. These are the features which you can distinguish on OCT rather than clinically. Again, if you see this in cases young person coming with a diminution of vision, solar retinopathy is very common. There is a small breach in the outer retinal layer in the foveal region, and it is usually seen in young people, solar retinopathy. Again, one important exclusion is exclusion of mactal. Mactal is very important. You will see a dot-like hemorrhage. You can see a pigmentation around the fovea, and initially you will feel that it will give a picture of a CNVM. These patients can, unnecessarily be labeled as CNV and can be treated like CNV, which has to be, very, very carefully seen, and mactal should be ruled out. Now, the newer modality and multimodal imaging modality, what I was talking about, is that OCTA is now coming as an important tool since it's a non-invasive direless angiography. It is based on reflectance of flowing RBC, that is the RBC which is flowing in the vessels. It only shows the blood vessels with flow of blood. So the presence of any flow is very important to know, that presence of any flow signal posterior to outer plexiform layer and anterior to choriocapillaries is usually pathological. It's very important because that's the avascular zone. And if you find anything, any blood flow in that area, that means it will tell you about the presence of neovascularization. So this is how it gives you a picture on OCT. You can see those various patterns of neovascularization. So these are all different patterns. You can see those of all the patterns. I would like you to focus on D. This is what is the dead tree appearance, where you can see those large vessels without the smaller vessels being present. And this is the sign of a disciform scar, and that is the presence of mature vessels and does not require further treatment. So these are the patterns. What is important, you must identify those patterns and you should carefully see those patterns. So basically, what is the application of OCTA is that wherever there is a doubt, when you have a doubt whether it is a CSCR with fibrin, Best disease, Mactal, and Whitlow disease, so there you can use OCTA to determine about differentiated with the CNV. It cannot, very important to note, that it cannot be used for decision to treat and retreat with anti-VEGF. See, that is very important. You cannot base your treatment on OCTA. OCTA is just a guideline. It will tell you about diagnosis. It will not tell you about the treatment, the treatment will always be followed up on OCT and not on OCTA. So the treatment will be based on the fluids, that is SRF, the intraretinal fluid, and the subretinal hyperrefractive materials. It can help you in guiding focal laser of extrafoveal CNVM and PDT laser spot determination, because you can see those entire membrane and you can decide upon the laser spots. So that is the application of an OCTA. Normally people think and believe that yes, you can base your treatment on OCTA. It's not correct. So this is what is important. This OCTA, this flow of vessels appears at those white, yellow dots. And you can see this avascular, I said about this avascular retina. You can see those membrane in that avascular retina, and that is the indication of an CNV. So important part is now the treatment part. We all know that how dietary supplementation, various studies have been done, how dietary supplementation is an important form of treatment. Then the photodynamic therapy, intravitreal anti-VEGFs, the combination therapy, surgery, and the laser photocoagulation. So the various studies we all know, we must know, we should know about the studies about the laser treatment is that MPS studies, the extrafoveal or the juxtafoveal classical CNVM treated with argon and krypton lasers had better long-term visual acuity compared to the baseline compared to patient who did not go this laser therapy. That was the starting of the laser therapy. Of course, it led to a bad scar of the fovea, and this was it was only restricted now to the extrafoveal lesions. The TAP study, which came later in 2001, it established the role of PDT as an effective form of effective form of therapy. It reduced the risk of moderate and severe loss for at least 2 years. Then came the VIP study. The VIP study was established, again, both TAP and VIP studies in 2001, that PDT therapy provided marginal benefit in treatment of occult CNVM also. So that is where the PDT started playing an important role in the treatment of CNV. Post 2006, with an advent of anti-VEGF, there was a paradigm shift in the treatment of CNVM. The two studies which started this shift of treatment was Marina and Anchor study, where it was proved that anti-VEGF therapy with ranibizumab was demonstrated to be an effective treatment in all types of subfoveal CNV lesions. We all know that it is not possible for a monthly treatment. It was based on a monthly treatment. So it was not possible for patients to continue with a monthly treatment with anti-VEGF. So the Pronto study, which came in 2009, the results were comparable with Marine and Anchor, and the PRN regime became more in vogue, and it started with better results than the monthly treatment. The OCT was used as a follow-up in PRN. The patients were called up and followed up with OCT, and whenever the treatment was required, they were retreated based on whether the fluid was present. The various criteria was used, that clinical criteria, whether there was a drop in the vision or on OCT, and there's a fluid which is intraretinal, subretinal, or which was present, and the thickness, the CRT, with the CRT increased, the patients were retreated. Again, with View 1 and View 2, which came in 2012, another anti-VEGF which came in, which showed a lot of prominence because of its longer duration of action, was aflibercept, where it was used monthly or 2 monthly after initial 3 loading doses, and produced a similar efficacious results as monthly ranibizumab. We now see that with the advent of anti-VEGF, people started using less of PDT. And that is how the lasers slowly, gradually went into out of vogue, and that is why over a period of time, even this drug, which was vertiporfin, and the laser were withdrawn from the treatment protocol. The radical study, again, which was which was published in 2015. It studied on the combination therapy, which did not show a significant benefit, combination of anti-VEGF and lasers, and did not prove much significant than anti-VEGF alone. Then, as 2018, the newer generation anti-VEGF came in, the newer generation with longer action and a better drying effect started pouring in with the launch of brolucizumab, the Hawk and Harrier study, which was started in 2018 and completed in 2020. It was very promising results. The duration of re-injection were Q8 to Q12 weeks. It is at present the most efficacious anti-VEGF till date, but it did not come like that. There were a lot of apprehensions of IUIs reported in brolucizumab. Initially, there was a lot of apprehension, including in our country also, that it can cause sudden blinding visions and a lot of IUIs and occlusive vasculopathy. But a lot of studies were later on done and proved a good safety profile of this drug. But it is very important that we must absolutely counsel our patients before giving this injection, because it can happen even in the third or the fourth dosage. That means it not necessarily may happen with the first injection, but it can happen with the later on injections also. And it can lead to loss of sight, though we have not yet seen, because we have used more than 2,000 plus injection in our center, and we have not seen even a single eye being lost. But it is very important to give a written consent. It's important for you also to know that whenever you ask the patient to take brolucizumab, you must give a written counseling that these are the things which can happen after injections. Then came the Tenaya and Lucerne study with another drug, faricimab. So 6 milligram faricimab. It has two ligand action, that is on two fronts. It is not only an anti-VEGF, but an Ang2 also, attacks on Ang2 also. That's but efficacy-wise, it is not as efficacious as brolucizumab. But the duration duration is worth mentioning. That's again a long-acting anti-VEGF. After 3 to 5 loading doses, you can achieve an interval of Q8 and Q16. The dietary supplementation, we all know the various studies, that is ARED1 and ARED2 study. ARED2 study, which is currently being followed, that high doses of antioxidants reduce the risk of progression from intermediate to advanced AMD by 25%. And the formulation of antioxidants, normally it is asked in examination during table viva, that what is the formulation of antioxidants in the ARED2 study. That is, zinc oxide is 80 milligram, cupric oxide is 2 milligram, vitamin C is 500 milligram, vitamin E is 400 international units, and lutein and zeaxanthin. Whom should we give this ARED2 formulation? Any person with intermediate AMD with other eye showing advanced AMD, multiple soft drusen's, and of course, advanced AMDs. So PDT, again, it requires a mention, because PDT is not only clinically, it was an effective form of treatment, but it's also very important theory questions. So PDT is photodynamic therapy. PDT can be used as a rescue therapy in patients not responding to anti-VEGF monotherapy. This is the role of PDT in a CNVM. It causes selective destruction of the target lesion. Why it is important? Because other lasers, it can completely damage the other areas also, but PDT, the drug selectively targets the tissue which is to be destroyed, and sparing the surrounding normal tissue. The drug which is used as is vertipofin. It is a photochemical sensitizer drug. It is important to know that it is a photochemical sensitizer drug, and it is selectively taken up by the LDL receptors in any rapidly proliferating endothelial cells of the CNVM. So the dosage of verteporfin is 6 milligram per meter square body surface. It is again important to know the dosage as an intravenous infusion over 10 minutes, followed by laser treatment after 5 minutes. The low intensity laser light, which is 689 nm with an energy setting of 600 milliwatts per centimeter square for 83 seconds. It's important to know that it is only for 83 seconds. Applied subsequently can activate dye and causes dissection of cell through photochemical reaction. So it is not a, it is a photoreaction. It is not a, it's a heat therapy or like any other laser. It does not induce heat. It does a photochemical changes, and that is how it destroys the selected tissue. It is important to avoid sunlight, and the patient is asked to cover up everything. There's no light in the room where he's waiting. There's no light. He has to wear goggles and sit inside for almost 30 minutes to 6 hours. We normally tell the patient to be inside for 6 hours till the effect of the dye goes off, and then only he can get exposed to the sun. The follow-up was done at 3-monthly interval with FFA and OCT. However, the complications, it can cause choroidal hemorrhage, it can cause RP rips, it can lead to photosensitive reactions, especially in the skin. It can cause hypertension, backache, dyspnea, and flushing. Anti-VEGFs. These are the anti-VEGFs normally available. Currently, these are the available anti-VEGFs. Injection ranibizumab. These are the FDA-approved anti-VEGFs. Ranibizumab, which is available in 0.5 milligram. Aflibercept in 2 milligram. Brolucizumab and faricimab as 6 milligram. All the formulation is available in 0.05 ml. So adverse effect of anti-VEGF is very, very important, because nobody normally, when you write, you don't ask for a history of any stroke or CVM, which is very, very important. Anybody who's undergoing an anti-VEGF therapy should be a good history should be taken from them, because it can definitely increase the incidence of stroke, CVA. It can cause thromboembolic episodes. We have seen 2 cases of stroke in our center, and hypertension, or it can also cause ischemic heart disease. In ocular, again, it's important to note that it can increase the IOP. It can cause endophthalmitis. So one should not haphazardly give this, because any injection is a risk factor for endophthalmitis, and it can also increase the incidence of cataract. And one must also see that it is, that the injection is placed in a correct position. Otherwise, you can put your needle inside the cataract and cause iatrogenic cataract in this case. So when do we give anti-VEGF? It's very, very important when. So the criteria for injection of anti-VEGF on OCT basis, when you see an intraretinal cyst, when you see the subretinal fluids, when you see sub-RP fluids, and when there is a generalized increase in the thickness of the retina. So what are the modalities of treatment? You can have as a PRN, treat and extend, and monthly. So what is a PRN? For that, you have to closely follow up the patient with frequent office visit, and patient comes to you, you do all your investigation, do OCT. If you don't see any changes in the status of OCT, you again call up the patient after 4 weeks. Whenever you see this patient having disease activity getting flared up, then you treat these patients. So the patients are normally called up, they're overburdened with frequent follow-ups. The other more practical and more effective form of treatment is treat and extend. So treat and extend regimen is it will minimize the number of intravitreal injections, office visits, and other testing. That means you, after the loading dose, you call the patient after 4 weeks. If you see that there is no activity, you again call up after 2 weeks. And irrespective of the activity, you give an injection. Then you again call up after call up after 6 weeks. And again, that means you are extending the treatment by 2 weeks. But after the 2 weeks, you are not monitoring the patient. You are treating the patient after 2 weeks. That's very important, that you're treating and extending the duration of treatment, 4 to 6 to 8, and you can go up to 10 to 12 weeks in treat and extend, depending upon the. So in ranibizumab, you can extend up to 10 weeks of treat and extend, and in the newer generation of anti-VEGF, you can go up to 16 to 20 weeks. In brolucizumab, we have gone up to 20 weeks of the treatment interval. Again, monthly injection, which was, various studies like Marina Anchor described the monthly treatment. It is not feasible for a person to receive monthly injection for lifelong, because not only it will, the patient will not come up for follow-up, plus the amount of treatment, the burden or the cost is very, very heavy on the patient, and we will not be able to do in our country. So the Harvard study, various studies have been done on the PRN and the monthly basis. The study which Harvard studies described that if you give monthly, the gain is 11.2 versus the PRN where it is 6.9. But again, it is it is worth mentioning that these studies has not been quoted after that, and the PRN is equally effective. We have seen that PRN versus Marina and Anchor studies monthly, but then in PRN it is 5.6 letters increase, in Marina it's 13.12. But practically it is not possible for a monthly treatment, and one has to go for a PRN therapy. As I told you that, anti-VEGF, earlier the treatment was to halt the progress of disease. Now we are looking at the increase in the increase in the vision. Earlier it was halting the progress of deterioration of vision. Now we are thinking at increasing the vision. Surgery is, again, I told you that surgery, it is important. Whenever there is a subfoveal bleed, you have to see these cases. It's again a medical emergency, and you have to give an intraocular gas along with a subretinal TPA and anti-VEGF, and ask the patient to put a face down position. In all these cases, we give pure gas, either SF6 or C3F8, and subretinal TPA in 25 microgram dosage, and you ask the patient to be in a face down position. So the results are very gratifying, and you can prevent a permanent loss of vision in these cases. Suppose there is the breakthrough bleed, which is cause of vitreous hemorrhage, one has to go with a vitrectomy and give an anti-VEGF along with after the end of the vitrectomy. Other complication which can happen is retinal detachment and a cataract in these cases. Radiation therapy, we all know that radiation can destroy all these vessels. So in 2010, Cochrane systematic review of 13 trials of various designs concluded that the body of literature does not provide support for this. So that has gone out of vogue. That is very, very aggressive form of therapy for these cases, and it is no longer used. These are, for more of an educational purpose, not for practical, but more of educational purpose, that, radiation therapy was also started, and which was, proved that it's not going to be effective. It's more damaging than being helpful. Then the Torpedo trial, where, the combination therapy of low fluence PDT and ranibizumab was done, and it was studied with this trial. Laser photocoagulation remains FDA-approved treatment for exudative AMD. Can be done for extrafoveal and should be done for extrafoveal CNVMs. It will reduce the load of your requirement for the anti-VEGFs. So patient education and rehabilitation is very important. You have to counsel your patients. And counseling of patient is various aspect, the psychological aspect, the visual aspect. The patients are treated and the patient are shown how to use this ampicillate. It becomes a main form of education, that you give the AMSA chart to the patient and you tell the patient what they are supposed to know. This is a self-education. The patient will know based on AMSA that is there any fluid without even getting tested. He can follow it up with AMSA and he can come for the follow-up and treatment. Also, the environmental factors needs to be modified, more light, more reassurance, and use of low visual aids, especially, once the patient is very educated, he becomes very frustrated if he's not able to read, do his normal routine work. So low visual aid definitely plays a very important role in these cases, and also must counsel the patient for the risk of involvement of the other eye. That's very, very important. So normally the patient is asked, and the students also asked by the examiner, that what will happen to the other eye? So this is what the cumulative incidence of 10%, 28%, and 42% at the end of first, third, and 5 years. The presence of 5 or more drusen, 1 or more large drusen, focal hyperpigmentation, and systemic hypertension is an important risk factor. So the ARREST studies also described there is a 43% chance of developing advanced AMD in the fellow eye by 5 years, and 20% chance of conversion of this. This is very important question, that there is a 20% chance of conversion of dry AMD to a wet AMD. The type of CNV present in the affected eye, classic versus occult, appears to have no effect on the rate at which the CNVM will develop in the fellow eye. So the various studies, these are the studies. I'm not going to go in the details of studies. These are for practical purpose, for theoretical purpose. It's available in the slide on, so you can see those slides, and you must know in the various studies which has been clinical trials. In the wet AMD is important. The newer trials are also important because normally you are asked about it, and you should have an idea about what are the various trials. This is basically an overall picture of how neovascular AMD, how should you go about it. You can see in the chart and you can take it from the slide. You should know how one should go about in these cases. A special mention about pachychoroid disease. Pachychoroid disease is an important form. It's again an important form of a AMD, which is normally missed. And it is important because it has got a various spectrum in this. The spectrum is a pachychoroid pigment epitheliopathy, a pachychoroid neovasculopathy, that is PNV, a central serous chorioretinopathy, and a pachychoroid vasculopathy, which we all know as PCV. So it is important to know because the first 3 pachychoroid, there's an increase in the choroidal thickness, whereas in a pachychoroid vasculopathy, the choriocapillaries are compressed. So this is important. Of all the 4 entity, pachychoroid vasculopathy, that is PCV, is very, very important, at least in our setting. It is why it is important. It is considered as a separate form of AMD. Earlier, it was formed as the same spectrum, the same AMD, but it's a separate form of AMD. It is important. We see a lot of PCV cases. If you see an elderly person between age 50 to 60, sudden diminution of vision, if you see a large subretinal or sub-RP bleed without any drusen, please keep in mind PCV. So normally asked question is, what is the commonest cause in an elderly setting? A hemorrhagic PED or a hemorrhagic with a serious PED. PCV is a very important cause for this. This has been seen from the Everest and the Planet study, how it differs from the other CNV. It arises as a BVN, branching vascular network, with the polyps at the terminal. So that's important that there is a polyp, where in other conditions there is no polyp, and it needs it need not always be associated with a thick choroid. So thick, I told you that the choriocapillaries are compressed in these cases, and the choroid is not thick. I'll show you the photograph also. Why it is important? Because it requires a more aggressive disease. It's a very aggressive disease, and it requires an aggressive approach with multiple injections. So we have seen that of all the injections, aflibercept is preferred in PCV cases because it performs better than other anti-VEGFs. It will respond better when combined with PDT. And as I told you, there's an increased risk of subretinal hemorrhage as compared to other CNVM. Peripheral exudative hemorrhagic choroidopathy, it can be seen where you see a large hemorrhage in the peripheral retina, and it is considered as a peripheral form of PCV. Because it is peripheral, you can use extensive lasers along with cryotherapy. This is what I was telling about. There's a choriocapillaries are compressed in a PCV case, and this is how it looks on your fundus photograph, on OCT, and on OCTA. Another condition which is known as a myopic CNVM, it needs a special mention because it is a type 2 of CNVM, which is above RP. Why it is important? Because normally it is treated as a conventional treated as it is, 3 loading doses are used and followed by PRN. We have also started using a straight away as a PRN. You can also straight away go instead of loading doses, you can go with PRN straight away. And the drugs which have been used is normally is bevacizumab and ranibizumab. So we have also used pralicizumab in these cases with good results, which I will show you the results. Now the consensus is forming on a PRN dosing right from the beginning. This is a case where I would like to show a myopic CNVM, a 32 years old lady with an axial length of 26.12 millimeters, came with a complaint of metamorphopsia in right eye. And the BC was 6/9, received injection pralicizumab. And you see this, the thin choroid, it is difficult to pick up. The SRF need not be present always. That is important to note in these cases. At 8 weeks, again, the macula was dry and the patient is asymptomatic, remains asymptomatic till 12 weeks. We received the second dose of pralicizumab and it responded well to the treatment. At 28 weeks, the patient remains asymptomatic and the best visual acuity is 6/9. So the message is that whatever it is mentioned in book, you can try a new therapy and it is still effective, and patient responds to those cases. Another CNVM is an idiopathic CNVM. So what are the features of idiopathic CNVM? It is not usually seen in a younger population, not associated with any disease, retinal disease. It responds to treatment. That means it's a finite disease. The other conditions are usually not finite. Patients can keep on taking injection 20, 100, so many injections. But normally, after a certain period of time of treatment, this tends to die down, and after some time, there's no further requirement of treatment in this case. And these can be followed up when the CNV vessels, once they mature, you can stop those treatment in these cases. This is what it looks like. If you see this on the left side, as a projection of the CNVM on the left side and how it responds to the treatment. Again, you can see this on OCTA. If you can see this, the vessels which are down, these are the mature vessels. So these mature vessels normally indicates that it is a scar. It is no more. There are no more new. You can't see the finer vessels. No more new vessels, and these vessels have matured and do not require any further treatment. Post-traumatic CNV. It occurs. It's very important. We see that cases of a choroidal rupture. So it occurs through the break in the RP and Brooks membrane complex. There's a choroidal rupture is there. Normally at the border of it. It can cause a breakthrough through that and present at the edge of the choroidal rupture. It does not occur in all cases. So it's very, very important that whenever you see a case of a choroidal rupture, you follow it up to 3 years post-trauma and see those cases that they are not developing any CNVM. It is response to treatment, but it has a variable response to treatment. If you see this is how it, no foveal rupture, and the below the CNV, it's basically a non-foveal rupture site which can be seen below the CNV. This is how it will, again, away from the fovea, you can see the vessels which is growing on the OCTA, and this is how it will present on OCTA. So what are the differentials of a CNV? So the differentials you should know. You will be asked. There's a macular telangiectasia type 2, CSCR, a CME, which I've shown you. I've shown you about how it will look on a OCT, chorioretinitis, Best's disease, and adult onset of foveal vitelliform disease. So to recapture the lecture, we have described the types of CNV which is present on OCT, various etiologies of CNV, about AMD and the risk factors for the neovascular AMD, the various studies of neovascular AMD, the pachychoroid spectrum is important, and the general principle of management of CNVM. Thank you.
Thank you, sir.
Thank you, sir. Ankur, okay, you'll come after me. So, sir, this was a very huge topic and you really covered it nicely. And I'm sorry, you have to take almost a 1 hour lecture. And next time, Dr. Ankur, we can divide this into 2 parts, I think, right?
I think we should. It's a huge lecture,
Yes.
so it can be divided in 2 parts.
Sir, can you stop share for a minute, sir? Can you
Yeah.
stop share? The floating bar red button.
Yeah, Ankur?
Sir, it was a very nice presentation, and I believe residents have got a very clear perspective of CNVM, how to treat it, and how to identify.
Yeah, Ankur, I can hear you.
So we have few online questions which residents have put on this online platform. One of which is that with investigations like ICG, FFA, and OCTA, what do you think is the most important one, and how do we decide which one to do?
See, now if you see this, there's a paradigm shift of with the new modules. Actually, the investigative is a multimodal imaging is important now. Gone are the days when your standard FFA was used. Now it has to be used. You have to combine your OCT, OCTA, and an angiography or ICG along with that. You have to see complete picture in toto. You cannot have one picture that just based on OCT or based on OCTA. You cannot treat. So all these things have to be amalgamated into one, and a multimodal imaging form has to be done. Everything will give you some input, but you have to collate your inputs and then form the treatment basis. So everything is important, will give you some input, but multimodal imaging is the R of the day.
The second question that has been put on the group is, how do we decide which anti-VEGF to start the treatment on treating a patient of CNVM?
See, that's a very good question, because see, with the various anti-VEGF available, now the focus is shifting on a longer. See, we all want what should be the ideal anti-VEGF? Ideal anti-VEGF should be a longer acting without any side effects, not very costly, and producing good results. So the newer generation of anti-VEGFs do give you that. So we, if feasible, one should give as a longer acting anti-VEGF so that you can have a longer duration of treatment. But suppose if there's a cost constraint is there, a standard anti-VEGF like ranibizumab is good enough. You can start with that. But follow-up is very important, that all these cases should be followed up and should be explained. The need for multiple injections is very important, that the loading doses are required and then they will have to be followed up. That's very important. But if you have an option, you can go for a longer duration of longer generation, the newer generation anti-VEGFs.
Thank you, sir. There's one more question. How do we decide, should we use the PRN regime or treat and extend regime? How do we decide, and which should we choose?
See, I'll tell you what, it's very important that where do you practice, how well you are conversant with your patient. Is your patient willing to come back repeatedly, then in those cases, PRN therapy, because in our setup, when we call the patient, he comes back. So we can go with the PRN therapy. But ideal thing is the treat and extend, where the patient comes to you, you see, treat, and then keep extending. The patient will also be very happy that, the treatment is now not limited to just 4 weeks, and you are calling the patient after the increased duration. But yes, if you're going for a PRN therapy, you please tell this patient you have to treat, and not only treat, you have to educate your patient that he should come back in the following things. If he has to follow up his visual status, he has to follow up his Hamster grade, which I told you that he has to see that. In that case, he has to come back, and he has to be followed up closely at the treating physician.
Thank you, guys. Thank you, sir. Just last question. What to do when the patient develops disciform scar?
See, that is where you have to educate the patient that nothing can be done in that eye. And that is important, that you have to follow up the other eye. I have repeatedly told that disciform lesion, if it develops, vision goes down to counting finger. I have seen, patient being recommended injection, multiple injections is not going to help him, because he is not going to get a useful vision that eye. There is a need for the other eye to be screened, and if it is getting affected, the treatment at the earliest.
Praful sir, do you have any questions with you, sir?
No, I don't have any questions. But thank you, sir. You took a exhaustive lecture. I know you are very busy nowadays, and you still took out 1.5 hour for our DOS PEP. Thank you so much for that. Dr.
Thank you.
Ankur, do you have that certificate? Then you can share.
So right now, I don't have the certificate. We will be sharing.
Sunil, please share it. It's there in the group. So this is sir, what we have started. No, we have started providing certificate to all the speakers, and at annual DOS we'll give a frame certificate. I'll email you the certificate.
That's all right. That's all right. It was it's important to teach. We'll get this.
Yeah.
Thank you so much.
And just to remind you, you said you will finish in 30 minutes, but I was thinking, sir is so enthusiastic about the class. It took almost 1 hour, but it was nice. You were
It's a topic.
speaking.
It's a huge. It's
Yeah.
very important. It's a burning topic. Everybody.
Burning. And also you are making them understand the basics, which is very important. Instead of running, you are trying to make them understand each and every aspect. That was really great. Thank you so much, sir. Dr.
I think people will get little more educated on this.
Yes.
So
Now you can, Dr. Ankur, now you can conclude.
Thank you, sir. Thank you for taking out time for DOS PEP from your busy schedule. And I thank everyone, all the listeners. I thank Dr. Praful sir. I thank sir for joining us for this DOS PEP program on CNVM. Thank you and have a great night.
Thank you. Thank you so much. Thank you. Thank you, Praful.
Good night, sir.
Good night. Good night.
अरे सुनील तुम हो क्या सुनील